Hey everyone, welcome back to part 15 of our CPC exam series. Today, we're putting on our detective hats, because honestly, your primary job as a medical coder is basically to hunt down billable clues that are just hiding in plain sight inside medical documentation. But hey, before we whip out those magnifying glasses to start the investigation, do me a quick favor. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. It really helps us keep uncovering these coding secrets for you. All right, so let me ask you a question. Are you leaving billable clues behind in your operative notes? You see, medical terminology, it isn't just vocabulary. It's a highly standardized language. Catching the precise anatomical terms is literally the key to unlocking accurate code selection. If you treat this whole thing like a treasure hunt, well, anatomical terminology is the map that prevents claim denials and makes sure your practice actually gets paid. Okay, let's dive straight into our first set of clues. Laterality trigger words. Laterality is hands down one of the most frequently tested specificity elements you're going to see. Why? Because it directly dictates your side-specific code choices. You absolutely cannot afford to guess when it comes to which side of the body a procedure was performed on. Look at how these specific words map straight to exact coding modifiers. Catching words like right or left dictates using the -RT and -LT modifiers. Spotting the word bilateral, that triggers modifier -50. Even functional terms like dominant hand in extremity contexts, or ocular terms like OU, OD, and OS for the eyes, those are massive clues. Missing these exact trigger words, it's going to force you into unspecified, unpaid codes, and nobody wants that. Let's move over to the topography specificity ladder and see how this builds up. Topography just means precise anatomical location. So look at level 1, lesion on arm. That is dangerously vague. As medical detectives, we are hunting for level 4 precision. A level 4 clue gives us the size, the exact segment, the surface, and the proximity. Something like 2 centimeter lesion, posterior right upper arm near elbow crease. The big takeaway here? Never settle for a level 1 diagnosis when the medical note holds level 4 clues. Level 1 gets your claim denied, level 4 gets you paid for the actual work performed.
And that brings us perfectly to these high-yield directional terms. Notice the stark contrast here. Proximal means nearer to the trunk, like your shoulder, while distal means farther from the trunk, like your fingers. Then for vertical positions, supra means above and sub means below. Reversing these simple prefixes completely ruins your claim because it points the pair to a completely different part of the body.
Next up, we've got those tricky look-alike directional terms. Intra-articular means something is happening inside the joint capsule, like a knee injection. Extra-articular means it's outside the joint capsule, like a ligament repair. So the crucial point to remember is that assuming all joint-adjacent terms are just the same thing will lead you straight down the wrong path. In coding, location is literally everything. Here is another classic look-alike mix-up I see all the time: condyle versus epicondyle. A condyle is the rounded joint surface at the end of a bone. It physically participates in the joint itself. The epicondyle, actually, scratch that. Think of it more like a projection above or near the condyle that just serves as an anchor point for tendons. Fair warning, picking the wrong bony landmark here will completely derail your code selection. Now, what about eponyms? You know, those terms named after people? Eponyms like Colley's fracture or McBurney's point aren't just medical trivia, they're translation triggers. A Colley's fracture points you precisely to a specific anatomical region, the distal radius. McBurney's point directs you straight to the right lower quadrant of the abdomen, specifically right by the appendix. You really have to treat these as direct pointers to location specificity. So, how do we put all this together? Well, here's your ultimate procedure note hunting checklist. Whenever you're scanning an operative note, look for these 5 things. First, the approach. Was it open, endoscopic, or percutaneous? Second, the specific target structure. Third, the depth or tissue plane. Fourth, anatomical landmarks. And fifth, any additional work performed. Master this list, and you're golden. To wrap up today's investigation, here is a 1-page visual summary cheat sheet. I highly recommend you take a quick screenshot of this for your daily coding workflow. It gives you a rapid-fire summary of all our high-yield clues, your laterality modifiers, the topography ladder, those look-alike contrasts, and eponym translations. Keep this handy to dodge those audit risks. Before we wrap up this explainer, I want to leave you with a bit of a provocative question. Do you truly understand the power of the 7th character in an ICD-10 CM code? Getting it wrong can instantly bounce your claim. So coming up in Part 16, we're diving deep into the ICD-10-CM. We're going to cover its purpose, code structure, rules for decimal placement, and those strict guidelines for the 7th character extension. You definitely do not want to miss it. Thank you so much for joining me, and I'll see you in Part 16.